Good evening, everyone, and welcome to tonight's Together Facing, which is focused on cancer and aging. I want to first thank our patients and caregivers and advocates and guests for joining us tonight. I'm David Wiest. I'm the Scientific Director of Fox Chase. And tonight, my colleagues and I are going to discuss why cancer occurs primarily in older adults and how their age can affect their care. Throughout the program, please feel free to leave your questions in the chat feature of Facebook, and we'll get back to you later in the evening. There'll be a question and answer part of the program, but if we can't get to your questions, then we'll do it later. At our Together Facing events, we traditionally begin with honoring those that we've lost to cancer. So please join me for a moment of silence. Thank you. I'd like to take this opportunity to also thank our exhibitors this evening. It's because of their generous support that we can offer this program to you free of charge tonight. Our special thanks are to our gold exhibitors, Bristol Myers Squibb, Caris, Excelsis, Genentech, Natera, and Pfizer, and our silver exhibitors, ADC Therapeutics and AstraZeneca. So just to give you a sense of how the program will go tonight, I will first introduce the panel, and then the panels will address a particular aspect of cancer and aging. And then we'll open up the floor for questions. And again, please post those questions in the Facebook, in the chat feature there. So I'm Dave Wiest again. I'm the Scientific Director at Fox Chase, and I'm going to be moderating this evening's panel discussion. We are fortunate to have a truly stellar panel of experts. And they are Dr. Lu Chen, who's an assistant professor at Fox Chase in the Cancer Signaling and Epigenetics program. He was recently joined us from Stanford, and he'll discuss ways to measure age. We have three clinical researchers who have to wrestle with the challenges of changing treatment approaches based on a patient's age, and they are Dr. Efrat Dotan, the chief of the Division of Gastrointestinal Medical Oncology. She's an associate professor in the Department of Hematology and Oncology, and she's a national leader in geriatric oncology. Dr. Zachary Frosch, an assistant professor, is in the Department of Hematology and Oncology, was recently recruited from UPenn, and he treats patients with blood cancers. Dr. Martin Edelman, who's the chair of the Department of Hematology and Oncology, he's the associate director for translational research, and he's a national leader in lung cancer and the challenges of tailoring treatments based on age. And lastly, we have Anjali Albanese, who's a social worker, and she'll talk about how patients, how their home situation factors into their care. So cancer and aging is a complex topic, but it can be broken down into two parts. First is why cancer mostly happens to us as we get older. And secondly, how doctors take our age into account when they treat us. So why do we get cancer with age? We used to think it was because people accumulated changes in their DNA over a lifetime, and when we hit some magic number of mutations, cancer would develop. But more recent research suggests that that's not actually the case. In many patients, the cancer-causing mutations actually happen very early in life, but those cancers just lie there for decades before the cancer is detectable clinically. So why is that? We now think it's because there are restraining forces that keep the cancer in check, and cancer only develops when those restraining forces get weaker with age. An example of how powerful these restraining forces are comes from work of our former colleague and Fox Chase professor, B. Mintz, who showed that when cancer cells were injected into a mouse embryo, they were wrestled into submission and became normal tissue, even though they retained all of the mutations necessary to cause cancer. So the restraining forces that we have that decline with age include strength of the tissues to restrain the cancer cells, and they kind of act like a cage. Your body's immune system, which can battle those cancer cells and keep killing them off. And unfortunately, these restraints decline with age, and when they weaken to the point where they can no longer beat the cancer into submission, it breaks out. And we experience the diagnosis that we all dread. So is there anything that we can do to slow the decline in these restraining forces? Well, yes, we can eat properly, high protein, low carb, we can exercise, we can keep our weight down. There are also medicines that one can take that can slow the decline. Recent research suggests that a molecule called Alpha-Ketoglutarate, which is already in our own cells, can be taken, and it's shown in mice that it increases the length of which they live and also how healthy they are as they live to an older age. And this has been shown to be true in people as well. So there are definitely things you can do to increase your chances of staying healthy. So the second aspect of aging and cancer that we'll deal with tonight is how doctors change how they treat based on the age of the patient to make sure that the treatments are maximally effective and have the least toxicity possible. And it's not as simple as just checking the calendar and seeing what age you are, because not all 65-year-olds are the same. I mean, think about hard partying rocker Keith Richards versus the eternal teenager Dick Clark. For doctors, it's not always clear by looking if you're dealing with Keith Richards or Dick Clark. So we need accurate ways to measure the impact of someone's life history so that the treatments they receive can be appropriately adjusted. So our next speaker, Dr. Lu Chen, is working on ways to develop tests that will help doctors distinguish Keith Richards from Dick Clark. So Lu, take it away.
Thank you, Dave. It's my pleasure to be here sharing some of the basic cellular and molecular perspective about aging. Specifically, I wanted to share with you with examples of why cancer arises at an old age. So I want to start by prefacing by saying our body is made of trillions of cells, and there are different cell types such as the blood cell that David is studying, and also lung cell, pancreatic cells. Some of the panelists are treating the patient every day. So what's remarkable about these cell types is all of these cells are shared with an identical copy of a manual, if you will, or blueprint, which are DNA molecules stored in a book such as this. So the faithful execution of this DNA manual is ensured by several molecular mechanisms, particularly epigenetic mechanisms. That backs to what Dave were introducing. So epigenetic means epi means something on top. Genetic means something written in the DNA. So epigenetic does not rewrite the order of the pages in the book in the ladder of ATCG, but rather it changed the manifestation of this genetic program or expression in specific cell type. So two particular aging-associated epigenetic mechanisms I wanted to talk today are two. First is called the telomeres, which is the end that caps the linear DNA molecules. And if we use the book as an analogy, that will be the hardcover of these books, where you have a beginning of the ends of the book. They're protected, these DNA molecule at both very fragile ends. The second epigenetic mechanism I envision are called epigenetic bookmarking system, which essentially the cell is using this epigenetic bookmark to place specific chemical modification at a specific region of the book. So it serves as an indexing system to tell the cell, okay, this is a program to be a blood cell, this is going to be a neuron. So then it can ensure the timely and efficient access of this manual to direct the cell to assume the proper cellular identity. However, the relevance to aging comes here. So while we are aging, the telomere hardcover of this book gets progressively eroded. So you can think about this old library book sitting in the library for 70 years old, and eventually the hard copy of this book is going to be wear off. So instead of the DNA pages in the book become more disorganized and more chaotic, and sometimes the DNA pages can lost. And also as a consequence, some of the nice bookmarking mechanism by epigenetic modification also gets gradually lost or rewritten. So under this chaotic system, individual cells get very confused because they can no longer assume the proper identity and the function that our body relying on from day to day. And in addition, such disorganization are exactly the ingredients that cancer prey upon and thrive within. Because cancer cells, they wait very patiently for decades, often in their very benign state. And once they seize this opening or weakness of our body or cell, for example, like Dave said, alluded earlier about the reduced immune surveillance and lost immune memory or heightened stress level or inflammation, and they found opening, so they become more aggressive and develop faster. And to make this situation actually work, the cancer cells are very good at learning. They're smart. They can actually exploit these mechanisms, such as the hardened book covers to protect cancer DNA, as well as they were able to rewire the epigenetic bookmarking system by inserting an additional new bookmark into this DNA manual. Some of these bookmarks leads to a new chapter called cancer. So here at Fox Chase Cancer Center, we are learning how cancer can exploit this aging-related weakness and fragility. And we're trying every day to devise novel therapeutics to revert this oncogenic invention. We're applying cutting-edge molecular assays to quantitate telomere and epigenetic bookmarks, the two pathways I talked about. We're applying these methods in patients and with an attempt to use these two aging clocks to determine the true cellular and the functional aging status of the patient, which can serve as a better predictor or marker for fitness for cancer patients. And also it can predict for therapeutic tolerance to chemo or surgical procedure, and also eventually the outcome for the patient. In order to achieve this goal, oncologists, clinical trialists, and basic scientists such as myself are working in a true team fashion at Fox Chase to develop the next generation personalized cancer treatment and management for Fox Chase patients. One of such example is the collaboration between my lab and with Dr. Alfred Dotang, who's going to present the next. Yeah, thank you. And
thanks, Lou. So Lou is going to study epigenetic changes and use those to distinguish Keith Richards from Dick Clark. Efrat will talk about what she's going to do with Dick Clark and Keith Richards.
Well, good evening, everyone. Thank you so much for joining us to talk about this very, very important topic. I'm a medical oncologist. I treat mainly patients with GI malignancies, but I have an interest in research and care for older adults with cancer. And I'm really focused in my research and trying to understand two main things. One is, how do we clinically understand which patients can receive which therapy, and how can we differentiate between an older patient who is very fit and should be treated with aggressive regimens versus patients who are more frail and we need to really adjust their treatment in order not to hurt them during the process. And I'm also interested in trying to look at our chemotherapy regimens, look at our other treatment options, and understand how we can adjust those treatment options so they can be used more safely in an older and more frail patients. When we think about cancer in general, I think our initial image is thinking about younger patients. We hear a lot about children with cancer. But in fact, cancer is a disease of older adults. And most of the patients that have cancer are older. We know that our population in general is aging. We have overall in the US, a higher and higher number of older patients. And in the near future, I think the estimate is about 2030 or 2035, we will have more individuals over the age of 65 than under the age of 18. So in general, our population is aging. And as Dr. Liu explained so well, as our body ages, the risk and the chance of encountering cancer continues to rise. And that's why there is a rise and increase in the number of patients who are older with cancer at the same time as we see our general population aging. So why is it so challenging to care for older patients with cancer? Well, number one, most patients with cancer who are older have other medical issues, and those medical problems can definitely cause interactions with our treatment approaches, limit some of our treatment options, whether it's surgery, radiation, or chemotherapy, and also affect how patients really tolerate these treatments. In addition, patients who are older often require support and assistance in other areas, whether it's in their regular function, in their mobility. They may rely on caregivers to help them get to appointments. There's a lot more challenges in terms of delivering the care that we want to give. And then the last piece is that often oncologists have to scratch their head and figure out what kind of treatment to give these patients, mainly because the data that we have, how to care for a patient with cancer, comes from studies that were done in much younger patients. So when I see a patient who is 70 years old with colon cancer, I'm trying to think about what is the best chemotherapy option for them, but yet all the data that I have from clinical trials are from patients who are in their 50s and 60s, which clearly does not fit to an individual who may be more frail and have other factors affecting their care. So how do we do this in clinic? And there are many, many tools that have been developed. We're still waiting for a biologic test. I hope Dr. Liu and his colleagues in the lab will help me come up with something like that, like a quick test that I can check in the blood and know if the patient should get one treatment versus another. But today we really rely on clinical assessments. We call this a comprehensive geriatric assessment that really understands what is the patient's life like, what is their overall health status, looking at all their comorbidities, their function, their nutritional status, their support system, their psychosocial status, and putting all these factors together to really understand what treatment they can tolerate and benefit from. It's a lot of hand-holding in clinic, talking to the patient, and really understanding what are the patient's goals and wishes before we actually determine their treatment options. We have two other medical oncologists here who will kind of talk more specifically in their areas. We have Dr. Zach Frost, who's going to talk about hematologic malignancies, and Dr. Marty Ellman, who will talk about solid tumor and specifically lung cancer. And I hope they give you a little bit of a sense how would they do this type of thing in their own diseases.
Thanks, Efrat. So next up is Dr. Zach Frosch. Zach?
Hi, everyone. Good evening. Thanks so much for joining us. I appreciate you taking the time. So as Dr. Dotan mentioned, I'm a malignant hematologist, which means I treat blood cancers, and specifically I focus on lymphoma. And so to get a little bit more specific with some of these issues, wanted to talk about it in that context. And there are many different types of lymphoma, and there are dozens of types, in fact. And we think about them in two main categories. And we think about indolent lymphomas, which are the slow growing ones. And then we think about aggressive lymphomas, which grow much more rapidly. And because they grow more rapidly, the aggressive lymphomas often cause patients serious problems, the time up to and then again right after their diagnosis. While indolent lymphomas may not cause a problem right away or may not cause a problem for a long period of time. And because of this, we think about the timing of treatment and really our whole approach to treatment very differently depending on the type of lymphoma that a person has. So for patients with these slow-growing lymphomas, in general, the time we think about starting treatment is when that cancer starts to cause a problem. And before that, we usually take what's called an active observation approach, which means that we closely watch how our patients are doing with respect to their symptoms, with respect to their labs, and also monitoring their lymph nodes, which is generally where these cancers most often occur. And we do that either with an exam or with imaging, depending on where the lymph nodes are. And so I mentioned that with this type of lymphoma, we start treatment when it causes a problem. And so what could those problems look like? It could be causing a problem because of where it's located or how big one of the areas of the lymphoma is. And it might be pressing on something in a way that blocks an organ from functioning properly. And so sometimes when we're in this active observation strategy before it's causing that problem, it does sometimes feel strange and anxiety provoking for patients to be told they have a cancer, but then to say, well, it's really actually best that we hold off on treatment at first. And we do that even though it might feel strange because we've learned that treating these type of indolent lymphomas before they're causing a problem for patients doesn't actually improve how patients do compared to when we keep a close eye on the lymphoma and treating it later when the problems develop. But meanwhile, if we were to treat the lymphoma earlier than necessary, it would actually expose our patients to additional treatment that wouldn't really benefit them and the side effects of that treatment. And this is a very different approach than we use in a different category of lymphomas, as aggressive lymphomas. And the most common type of lymphoma in general, and the most common type of aggressive lymphoma, is something called diffuse large B-cell lymphoma, or DLBCL, which is what I'll call it for short. And in contrast to what I was talking about earlier, at the time they're diagnosed with DLBCL, more than half of patients are really experiencing a lot of symptoms typically because it's growing rapidly. And all lymphomas are diseases of aging, just like cancers that other people have talked about. And so when people are diagnosed with DLBCL, half are over 65, nearly a third are over 75. And as Dr. Dotan mentioned, at this age, there are potentially some really big differences in people and how they're doing at the time when we're thinking about starting treatment. So some patients who are this age are very active, very socially connected, and really have high levels of support from their family and friends, but others may have a lot more difficulty physically, mentally, or socially. And one challenge with this particular type of lymphoma is you really have to figure out what's due to the lymphoma and what was there beforehand. So at the time we're meeting people for the first time, they might be feeling much worse than they had a few months or even a few weeks ago. And some of that can be due to the cancer. Patients might be losing weight, they might be being less active, they might be feeling anxious, scared, and potentially withdrawing socially, all due to the symptoms of the cancer. So when you meet someone for their first time in the midst of all this, you have to talk to them about how they were doing before, you have to talk to their family members who know them well. And sometimes actually a change is most apparent to somebody who's a family member or a friend who sees your patient every few weeks or every few months, because it's really such a stark difference since the last time they saw them. And the reason it's so important is, as we've been talking about, is that especially for aggressive lymphomas, this start of treatment is the time when patients can see the most rapid benefit. So we can really sometimes make patients feel a lot better really quickly, even after a treatment or two. But it's really also the time when they're at the highest risk for potentially serious side effects from that treatment. And we know that there are people who these aggressive treatments can really help, but also people for whom doing the same thing has really a greater likelihood of causing side effects than providing them with real lasting benefit. And we also know there's a group in the middle who is both at risk for serious side effects, but also potentially may have some real benefit. So you have to be really attentive and really make the best individual decision you can with your patients and their families about which direction to go in and what you think is going to be best for them.
All right.
So
Thanks,
I'll
Zach.
kick that back to you, Dr. Reese.
Okay, thanks, Zach. That was great. So next we'll hear from Dr. Marty Edelman.
So I just would echo what my colleagues have said. Cancer is a disease of aging. The median age for patients with lung cancer is about 70. So thoracic oncologists, those who treat lung cancer, are very used to dealing with an aging population. Having said that, similar to what was also said, is most of our treatments were developed frequently in trials in younger patients. And there are definitely issues of tolerability for treatments in the population as it ages. So there's I think, pressing need for us to be doing studies that take this into account and the various, techniques that we use to assess somebody's ability to receive treatment. I think at the same time, there may also be some clues in this as to how we can probably end up with less toxic therapies in the entire population, because if it turns out that lower doses produce similar effects in an older population as we possibly saw in younger people, then there may be that nobody needs those higher doses. And so to some extent, the fact that we are beginning to see this in studies that are done in older folks may in fact educate us about how to treat younger people. In my own practice, it's very typical for me to see people well into their 80s. And I think one of the other big issues that needs to be addressed is the tendency not to want to treat them. And in particular with lung cancer, there's a certain stigma as well that's been associated. And, sometimes I have to convince patients that being treated for lung cancer when you're 70 or 80 is a totally suitable thing to happen. I have a vivid recollection. I have one patient, a woman who came to me. She was 80 or so, had small cell lung cancer, had been told that she should not receive treatment and to go home and, sign up for hospice. And she was otherwise pretty fit. She was doing yoga every day before this, hadn't smoked in a very, very long time, and was is a pretty vivacious individual. And so I said, well, yes, we should treat you. And based upon my prior experience, I treated her, but with significantly lower doses of drugs than we had used before. And to make a long story short, we're now 3 or 4 years into this, haven't done anything with her in a couple of years. And she's doing fine, practicing yoga. And in fact, one day came in and was talking about her hot date with a younger man, her dentist who was 79. So, I think that it's very important that we all recognize that, there's people age at different rates, and there are many people who, it's more than, it's not just a number, and yet that's how it's frequently viewed, even by the patients themselves. And I would hope that we will have better ways of figuring out the physiology of these patients and how to adjust our drugs. I think one thing that's happened over the last 10 years in medical oncology is we increasingly have medications that are both more effective as well as better tolerated. Those come from clinical trials, and it's critically important that these trials include the full population, which includes having people into their 80s. And, once again, anecdote, I have a patient of mine who I saw not long after I arrived at Fox Chase, and we placed him actually on a very aggressive regimen. He was 80 at the time. I still see him back. He is now 85. So he was treated. Did he have some side effects? Absolutely. But he's doing well. And his wife, who's a volunteer at Fox Chase, stopped me in the hallway a couple of weeks ago and said, I never thought, Bud would be around this long. And so, once again, age is more than a number, and people may still be living very full lives. And it's very critical that we treat them appropriately and not withhold treatment. And I think the numbers in the country are such that outside of many centers, these patients are in fact not treated. And statistics are actually kind of scary in that substantial fraction of patients. I know for lung cancer, where we have increasingly effective agents, probably over a third of patients never receive any treatment for advanced disease, despite very clear evidence of benefit. So it's more than just even figuring out how to treat people. It's sometimes figuring out whether or not they should be treated and making sure that these are available to the full population.
All right, thanks, Marty. Very informative. And so our last panelist we'll hear from is Anjali, who is a social worker, and she'll talk about sort of the support systems and how that impacts how we treat our patients.
Thank you, Dr. Wiest, and thank you to all of you for joining us this evening. As Dr. Wiest said, my name is Anjali Albanese. I'm one of the social workers here at Fox Chase. I truly view the role of social work as kind of putting pieces of a puzzle together. We recognize that when you enter our front doors, that you were a whole person before you even came to Fox Chase. You had family, you have support systems, you have interests and hobbies and all different things that make you who you are. And I view the role of social work as part of our job is to recognize that and to help the treatment team get to know you in that capacity so that we really can appreciate the things that are most meaningful to you. Part of what social work does at Fox Chase is offer support services. We understand that a cancer diagnosis is scary, it's stressful, there's a lot of different emotions that are associated with it. And so part of our role is to provide emotional support, and that's just not to the patients, but also to their support systems. And we do that in a lot of different ways. For some patients, they prefer talking to us one-on-one. For other patients, they prefer to come in and talk with their support systems. And some patients prefer to talk to other patients who are going through a similar experience. So we do offer support groups as well. We also are part of the treatment team. So I think that's where the role of putting the pieces of the puzzle together comes most in handy, because oftentimes we can help the treatment team sort of understand you as a person And not just the physical part, which is obviously why you came to Fox Chase, but also just the mental and emotional part, and recognizing the struggles that come along with it. And then also linking you up to community resources. For some of our patients, they come from quite a distance. And so we try to come up with different things that you can do in the community that can help provide some support. And also both, we do have things at Fox Chase, but like I said, sometimes the barrier can be distance. So we offer things we have internally, but then we also try to make things available to you that are closer to home. We recognize that oftentimes cancer comes with a lot of baggage. Some of the baggage is it increases some of what we call barriers to care. For some people, that includes stressful financial situations. For other people, it can be weakened social supports. And we understand that with an aging population, some of these issues become more paramount or more apparent as you go through the process. So we really do try to be sensitive to all of that. And we try to get to understand what are the things that you are most concerned with or struggling with, and what can we do both as the treatment team, as the social worker, and as an institution to help reduce any of those barriers so that we really are getting to know you and getting to know what things we can do to help guide you through this process. What I always say to all of my patients is my role is to be a support person to you, and I'm the person to call or find when you're not sure who you should be talking to or what your questions are, or trying to help you figure out where to go next. And if it's not me, I can always just point you in the right direction. So thank you for joining me this evening, and I hope this information was helpful.
Thanks, Anjali. I mean, navigating the cancer journey is tough, and knowing that that you're there to guide people through and help them connect up with the right experts in the center is comforting. So thanks for that. And I just want to thank the entire panel for their thoughtful remarks. So that concludes this part of the program, and now we're going to open up to discussion to our audience. So please, if you have questions, put them in the chat feature of Facebook, and we will address them for the remainder of the program. If there are too many questions to address during the remainder of the program, we'll certainly do it after and get back to you with individualized answers. So we'll start. Our first question asks, is the older population more at risk for specific types of cancers? So I guess the question is, are there particular cancers that are more prevalent in different age groups as we age? And so I guess we can all unmute and take a turn at answering. So I'm guessing that would either be Efrat or Marty. So if you want to take that first one, there are a number of questions showing up. So Efrat or Marty, sorry.
That's fine. Whatever. Efrat, you go first.
Okay. There's definitely tumors that we see in certain age groups. So, for example, sarcomas, there's certain sarcomas that we see more in younger patients. There are certain types of breast cancers that we see more in older patients. So there are definitely certain tumors that have predisposition to certain age groups. And, obviously it's very difficult in 2 minutes to talk about all the different types, but I think the general message is that in the more common cancers that we see, in the more routine tumors that you hear about, breast cancer, colon cancer, lung cancer, these are tumors that typically we tend to see more in older individuals.
Thanks, Efrat. Marty, do you want to add something to that?
Yeah, I think, to sort of echo, cancer is a disease of aging. The longer you live, the greater the likelihood of getting it. People say, oh, there's so much more cancer today. Well, that's because there's so much less tuberculosis, or, heart disease has declined, et cetera. Other causes of premature death are less. We actually saw somewhat of a reversion with this, with the pandemic, where, you had large numbers of people dying of infectious disease, or prior to that during the epidemic of HIV. And as those come under control, once again, cancer will clearly be the major cause. I think it's, important to recognize, the relative burdens of cancer. So for example, lung cancer, definitely a disease of aging. One accumulates those abnormalities, but what's it overwhelmingly due to? Well, there's certainly substantial numbers of patients with lung cancer who never smoked. About 85% is associated with smoking. patients started smoking usually in their late teens, early 20s, virtually nobody after 25, and yet the median age for lung cancer is 70. Similarly, those who are asbestos exposed, that usually happens over the course of decades, and it's about a 40-year lag time before one actually gets mesothelioma, or for that matter, the more common disease associated with asbestos, which is lung cancer. We all hear and see the commercials about, the tragedy of pediatric cancers, and they are a different kind of cancer. So as Dr. Dotan put it, sarcomas, certain types of brain tumors, et cetera, do occur in the young. But the burden of that, if one looks at all of society or, the population, there'll be 225,000 cases of lung cancer alone, and there will be 25,000 cases of all cancers combined from ages 0 to 21. So pediatric cancer, obviously a massive tragedy, and a major loss of, potential, is relatively small compared to the burdens of the four major malignancies, types of malignancies: lung cancer, colorectal cancer, prostate cancer, and breast cancer.
Thanks, Marty. So our next question is, what can I do to prevent cancer as I get older? I think I'll take a run at this one. So, there are a number of things. Marty just mentioned one. You can sort of not engage in quote unquote sinful behavior. Don't smoke, try to eat right, don't live on scotch and cheeseburgers, high protein, low carb, exercise, keep your weight down. And as I had mentioned during my opening remarks, there are things that are now being trialed in patients to see if they can prevent the decline that occurs with age and prevent the incidence of cancer. And one of those is called a rapalog. It's an analog of a drug called rapamycin that has shown some efficacy. The other one that I mentioned is a substance called alpha-ketoglutarate. And these are available, these kinds of compounds like alpha-ketoglutarate are available over the counter. You can get them in slow release form and take them. And they've been shown to be very effective in animal models of extending life and not sickly life, but very robust, vigorous life. And so I have a friend who actually just started taking it, and he lives in Singapore. And he said, I used to be able to just run maybe a mile or two. He said, now I feel like a kid again. So is it the fountain of youth? I don't know, but there are certainly things you can do to sort of decrease the decline that you experience generally with age. Obviously, exercise is one of those as well. So many things that one can do.
I would just like to make a comment that do not listen to anecdotes. As my good friend, Dr. Fadlo Khoury, the formerly chair of oncology or chief of oncology at Emory and president of the American University in Beirut, put it, nothing will kill a drug faster than being in a prevention trial. The trials we have done in prevention have generally not only been negative, but frequently harmful. And so there is one thing that really can be done. Number one, avoid tobacco, all things in moderation, and exercise. The one thing no American ever wants to hear, which is it's not a pill, it's actually getting up and doing things. That clearly works. It will improve everything. It will decrease cardiovascular mortality, and it doesn't cost very much. And you know what? You only need a doctor's note if you choose to live a life where you sit on a couch and watch TV and eat cheeseburgers. Then you should have a doctor's note, because that is known to be associated with a very high mortality.
There you go. Anyone else want to?
One other thing. Yeah, I mean, I think the biggest thing people can do is routine cancer screenings, right? Colonoscopies save lives, cervical cancer screening, mammograms, CT scans for patients, who have certain smoking histories. Those are things that have been studied in large trials and that truly save lives. And we lost, Marty mentioned the pandemic, right? People have had to put those things on hold. And so right now is a great time to pay attention to those things again.
Okay, thanks, Zach.
So
that's a great point.
One thing I wanted to echo what Marty was saying is to not fall into the trap of some of the sort of things putting out there without scientific foundation. For example, there are like a telomerase boosting molecule, and people thinking that are potentially fountain of youth. There are crazy CEOs are injecting themselves with a virus that overexpress the telomerase gene into the body and then seek to convince other people to invest to rejuvenate him or herself. However, there's the fundamental basis for the biology is the telomere shortening can also serve as a cancer suppressive role. So if you have elongated your cellular telomere, you're also meanwhile expose yourself under heightened cancer risk. So gotta be really careful and not fall into those traps.
Thanks, Lou. So our next question is, after a radical prostatectomy with clean margins, what kind of cancer or cancers can result from recurrence? Who wants to take a run at that one? I see you smiling, Efrat. How about you?
So I am a GI oncology, not a GU, but unfortunately, I think, you know, if the treatment was done just with surgery, just with radical prostatectomy, and there were no additional treatments like radiation, I probably would say that the risk of secondary malignancies are not high. That being said, we know that, you know, we do see patients with prostate cancer, which is the most common cancer that we see in older men, develop other cancers as well. So that doesn't mean you shouldn't think about screening for colon cancer and keeping a healthy lifestyle as discussed earlier. I'm not sure I can comment more about the treatment of prostate cancer more than that. I don't know if anyone else on the panel can.
I guess maybe a broader context would be, are there malignancies that develop after intensive therapies for other cancers? You know, radiation and chemo for breast cancer, et cetera. If you want to comment on that.
Yeah,
I can
absolutely.
do that too.
So,
too.
yeah. Yeah, maybe Zach would be better.
So the reason I kind of jumped in here is we think a lot about what we call, you know, secondary blood cancers after people have had treatment for their other cancers. And, you know, those are typically leukemia or related cancers. And so, you know, those can come up either, you know, soon, say a couple of years after people have been treated for something else, a different type of cancer with chemotherapy or radiation, or even, you know, a number of years later, like 7 years later. It's not a large number of people, but obviously we think very hard about it because in treatment for one cancer, you are assuming a small risk in these situations for a later blood cancer. And we have, you know, other members of the panel have been talking about de-intensifying the treatments in some ways, and we think about that a lot as a field. So what's the essential elements of treatment for cancer? How can we safely back off without compromising, you know, our cure rates, you know, or real benefit for patients? And so, you know, both, you know, the things we all do as medical oncologists, which is, you know, mostly, you know, is traditionally chemotherapy, though we're moving away from that now in many areas, and also radiation can cause secondary blood cancers.
Thanks, Zach. So our next question, and I promise you this was not a plant from a relative of mine. Why is it important to go to a comprehensive cancer center for cancer treatment? So because you get to meet people like Anjali. So Anjali, why don't you take that one?
Thank you. I think one of the main benefits is that, like I said in my talk, was that we really do look at the whole person. So as you can see from the panel of experts before you, everyone works collectively as a team and we all share information, but we also look at people not just from their physical aspect, but also their mental and emotional. And so oftentimes people have said to me that, you know, they may have come from another facility, they may have come from a community hospital where they never encountered a social worker. You know, they mostly just dealt with their treatment team. And then they said to me, like, I wish we would have met someone like you in the very beginning. Because oftentimes, you know, people are struggling early on. And so it's really nice to know that your whole being is what we are really directly interested in, and it's what makes you who you are. And our goal as an entire team is to make sure that we help get you back to that in the best possible way.
Thanks, Anjali. So one reason to come to a comprehensive cancer center is that you get a team effort. Anyone else want to weigh in on why it's best to come to a cancer center? Marty?
Yeah, so, I think that probably the best reason is increasingly care is multidisciplinary, and involving not only the physicians, but also social worker, physical therapists, et cetera. And the best coordination of that will, be at a larger, usually an actual cancer center that's a true university-based or academic center. And that's one aspect of it. So, where people are, actually working together, you're not necessarily batted from office to office, but frequently where, oh, you need to see this person. So for example, earlier today, I had a patient, their biopsy was inadequate for some of the testing was done at a local community hospital. And I walked, 30 steps down the hall, grabbed my pulmonary colleague and said, this gentleman needs a bronchoscopy. We need it done soon. And here's why I need it. And, no problem. And by, late that afternoon, this afternoon rather, he's contacted and getting ready. And that's one aspect, which is the team, and true multidisciplinary approaches, but also because, everybody says, oh, we have literature to guide our treatments, we have guidelines, et cetera. And, the difference between an academic and particularly an NCI-designated, cancer center is between practicing by the guidelines and talking to the people who actually write the guidelines. And I think that's the big difference. I can't necessarily guarantee anyone a better outcome, but I can certainly guarantee that I've thought a lot more about lung cancer, and Dr. Dotan has thought much more about pancreatic cancer, and Dr. Frosch about lymphoma than somebody who's a general oncologist. And I say this as probably uniquely of the group, the person who actually was a general hematologist oncologist for a few years. It's just simply not possible otherwise. And it's more than just that, you can read the article, you can read the literature, or you can write the literature. And it's also the availability of clinical research. As I've told people, if you're satisfied with the current things that we do, stick to the standard of care. If I'm only have the standard of care available, I have failed. We have failed. Not that every patient will get a trial, but at least we are thinking about it. We are part of it. We are formulating those studies. And, as one of our other colleagues has put it, a drug that is available in the community was generally available at a place like Fox Chase 5 years earlier.
Thanks, Marty. I guess to put it simply, if you own a Ferrari, don't take it to a Ford dealer to get it fixed. Come to a Ferrari dealer, and we're a Ferrari dealer. Our next question is, what clinical trials are open at Fox Chase for geriatric oncology, and how can I get involved in such a trial? So Efrat or Marty?
That's a great question. Thank you for asking that. So we currently have 2 studies that are in pancreas cancer. I do see a lot of pancreas cancer, and hence why I combine my 2 passions. We're actually with newly diagnosed older patients with pancreas cancer. Every single patient can go on a trial. We have a trial that's focused on fit patient, trying to get a very aggressive regimen and reshape it to make it more tolerable for patients. And we also have another study that's open for more vulnerable older patients with pancreas, trying to define the new standard of care for vulnerable older patients with pancreas. This is a large NCI trial that is being conducted across the US, and we're really excited that we're actually trying to get data in this very important patient population where we have absolutely no guidance as to how to care for these patients. In addition, in GI, we do have another trial focusing on patients with stomach cancer who are older. We're looking at their overall needs and challenges when they go through treatment. And we're also using Fitbit to try and understand the true performance status of patients, the true function of patients. So, you know, it's one thing to ask someone how much they walk. It's a very different thing to put a fitness tracker and see how much they really walk. And we're trying to see if that would be a tool that we can use in other diseases to really understand what patients, you know, what's their function and how can we use that data to define their treatment. So we have a lot of those things going on in GI. And as our program grows, we hope to have other diseases as well participate in this.
So
Marty?
What I'd like to emphasize first off that pretty much none of our studies have a ceiling on age. So all of our clinical trials across the many malignancies that we see, lymphomas, leukemias, et cetera, you know, as well as the solid tumors, lung cancer, prostate cancer, pancreatic, colorectal, et cetera, do not have an upper limit. So effectively, it's all research because once again, cancer is a disease of aging, and that's a key thing. And so then we have the things that focus on that population to better understand things. EFRAD's group is clearly the leading group at our institution and frankly, one of the leading groups nationally. We have a study that we're about to open shortly, and hopefully it needs to get through all the regulatory issues, where what I've done in lung cancer, both non-small cell and small cell, is to build in a methodology that's objective and prospective that will lower the doses of the chemotherapy, the drugs that typically affect bone marrow and other organs, you know, in response to things which include age as well as kidney dysfunction, prior therapies, et cetera, really getting at expanding our trials into the patients that we do not normally do, and where the current guidelines simply say, lower the dose or do something, but have no prospective validation. And so we will look at this from the standpoint first of, will they be tolerable? Is this the right way to adjust our doses? Because there's a certain arbitrariness to this. And then also look at efficacy. Have we preserved the efficacy of these treatments in these populations? So more than just looking at geriatric population, but also those with frailty, with kidney dysfunction, with prior treatments. And I think that those are the kind of studies that we need to be doing. Interestingly enough, the Food and Drug Administration is very easy, which are real world data, but assembled in a prospective, pragmatic way that does not involve excessive additional testing visits, et cetera, but tries to give objectivity to what we have previously done in a very subjective and idiosyncratic way.
Thanks, Marty. So our next question is, and this is for Zach, since he raised the issue of screening, what types of cancer screenings or tests should I get annually after the age of 50?
Yeah, so this actually was recently updated. So the age of colonoscopy is going down, and so if you're certainly over 50, you should have had your first colonoscopy already, and then based on that, then it will determine what they find out when you need your next one, whether it's 10 years out or a couple of years out. And then mammograms for breast cancer screening, cervical cancer screening, and then for a very specific kind of population in terms of lung cancer screening, if you smoked a certain amount, then you're also going to be eligible to get CT scans that'll look for early lung cancer. And this is a good opportunity to also talk about why screenings are so important. I mentioned earlier they save lives, but with all these types of cancers that I mentioned, catching them early while they're still in a small place allows us to administer treatment, whether it's surgery or surgery with radiation or some combination of chemotherapy, surgery, and radiation that gets to them early. because with the type of cancers I treat, blood cancers, blood's everywhere. And so your patients come into my office and, they say, what stage am I? And, it's probably, many of them are stage 3, 4. And I say, that doesn't really mean what you think it means, because people kind of get into their mind, because all of these other solid tumors are much more common, that once it's spread, it's much more difficult to treat. And these cancers, the ones that I'm kind of mentioning that are good screening, that you should be getting screening for, these screenings catch them early before they've spread, and really allow you to potentially cure a type of a cancer that you may not have been able to do if you caught it later. So so that's again why they're really, really important. And so there's no better time than tomorrow morning to call your doctor to get it done.
Thanks, Zach. Another question is, how would I know if my symptoms are from cancer and not just normal signs of getting older? So who wants to take that one? Marty?
So, that's actually a really difficult question. And I think, everybody gets aches and pains, and, and they have a different connotation when somebody actually has a cancer diagnosis. And it's not always easy. These things can be quite subtle. I think that, obviously people get screened for the major cancers: breast cancer, colon cancer, lung cancer, prostate cancer, plus minus, have, reasonable screening tools that are effective in this. But other symptoms, can arise, and sometimes they become quite subtle. I think that things that do not go away, that are getting worse over time, pain that's waking you up at night is always something that's there. Lumps that don't go away, again, there are things, that in general, it's even for the people who have diagnosis, lots of aches and pains. And of course, people are dwelling on these. And, I probably would too if I were in that situation. But as I tell folks, the symptom that comes and stays is the one that I begin to worry about, the one that wakes you up at night. Weight loss, involuntary weight loss, is a particularly concerning symptom for if it's not lung cancer, or I'm sorry, if it's not a cancer. That's a very frequent issue there, and one that, but it may be some other type of chronic disease that needs to be discovered in order to be treated. Fevers that don't go away, that persist over time, is another classic sign of early, malignancy. So probably the best thing is to have a good primary care physician and recognize that, because you showed up once for something, and it didn't, and it was dismissed, doesn't necessarily mean that it was totally benign. It's very hard. And I think this is really important. We're super duper subspecialists, and for us, it's like, for me, somebody has a headache, I assume it's disease that went to the brain, and I'll be right a good chunk of the time, because that's the nature of the disease that I treat. But if you're a general internist, a family practitioner, et cetera, a headache is usually a headache. And, it's usually going to go away. I mean, most symptoms are not a problem. And you see a lot of patients. And again, kind of I'm in a somewhat unique situation of being one of the few people in a very subspecialized environment now who actually did general medicine for a period of time. And I always had a rule: somebody showed up 2 or 3 times for something, it triggered a much more involved investigation. Sometimes you don't find anything, but that's what it is. I think it's the symptoms that come and stay, and they can be very vague at the outset. And that's hard for folks to understand and say, well, I told so-and-so about it. Yeah, but sometimes you got to return, because it's just not easy. I think the job of a general internist or family practitioner in many ways is far harder than what I do.
Thanks, Marty. I guess the one thing I would say, so skin cancer is an issue that runs in my family, and my dermatologist advises me to examine my birthday suit on my birthday. And so the advice is know yourself. And so if something's out of the ordinary, be aggressive in pursuing it. And if someone tells you don't worry about it, don't listen. Pursue it until you feel comfortable, because you have to be an aggressive advocate for your own care. And so the last question that has come through on the chat an interesting one, and this is one for each of the panelists to address, and maybe take just a minute to do it. What are you hopeful for regarding the future of cancer and aging, and what we can accomplish by focusing on this as a research area? So who wants to take a first crack at this? Anjali, Lou?
Oh, okay. Oh, okay. So this is a little bit about research, basic research. So I think we're trying to work on to get to the next generation of biomarkers that we can use to predict patient outcome. I think the key is first we have to do the early diagnosis as early as possible. That's a game changer. And also we're trying to find a way to be as non-invasive as possible, as frequent as possible to monitor the progression of the disease. So some of the interesting biomarkers that we are focusing on is the circulating cell-free DNAs that are readily available in patients' blood. That we can actually, the key to use these cell-free DNAs is the limited sensitivity and the background noise, because in the earlier cancerous state, there's a very few cancer cells actually are shedding this genetic material into the bloodstream. And that's almost identifying a cancer mutation. It's like finding a needle in a haystack, because there is an ocean of the normal DNAs that's only often one nucleotide away from the cancer mutation. So the way we're attacking this angle is to engineer by teaming up with mechanical engineers and to devise these nano-fabricated microchip, so that we can increase the sensitivity and couple with some of the cutting-edge CRISPR-based molecular tools to try to detect 1 out of a million molecule of the cancer-mutated genes. So with the hope that we can actually identify them early without significant pain caused by the biopsies. And in closing, I want to really say, all the physicians on the panel, just basically from my basic scientist perspective, all the physicians on this panel, they are true professionals. They really are very great about their craft, and also they deep care about the patients under their care. And I have a very personal experience of this aspect. So that's basically one part I think is awesome, to be coming to a comprehensive cancer center from the previous basic research institution I were in, University of Kansas and University of Stanford. It's all kind of like focusing my research in the basic laboratory in the ivory tower, if you mean. Once I'm joining the Fox Chase Cancer Center, I got a chance to work with this the best cancer doctors that are out there, and that they not only care about the care, and also they're trying to improve the patient's care, and they're trying to improve the current status quo all the time, pushing the boundary. I think that's one of the truly incredible thing I want to share with all of you today. Thanks for the opportunity.
Thanks, Lou. So Anjali, perhaps you could talk about what you're hopeful for in your domain and how you'll be able to help aging cancer patients in the future.
Well, my hope is that, as you see the expert of panelists before you, that we continue to strive to find treatments that are suited to people's particular lifestyles, and that people recognize that, you know, age is a number, but that there are things that you can continue to do both physically, mentally, and emotionally to help yourself as you move forward. And, you know, that we continue to make progress in this field, and that people feel well cared for physically and emotionally anytime they have to go through an experience like this one.
Thanks, Anjali. Zachary?
Yeah, so I'm hopeful that we will continue to develop treatments that are just as effective, but less toxic, fewer side effects, and we're headed in that direction. And I think in addition to being hopeful, that I think, you know, the reason that I'm hopeful is because people are really thinking about this, right? You've heard some of this tonight. It's a real priority, and it should be. And so I am hopeful that we're going to keep moving in that direction, and we're going to have just really better and better things to offer patients at a really difficult time.
Thanks, Zach. Marty?
So, we talk a great deal about personalized medicine, and that's more than just, a drug that hits a particular target, but also that the treatment itself is personalized for the individual, that it works, for their, for the many, many things that people, bring, including their, other medical problems, their status, age is part of that. And so, we need to be able to incorporate all of these features. I think ultimately, when people look at, well, what gets one excited about where the future is, we've seen dramatic improvements in every aspect of cancer care in the last 30 years or so. I mean, as I point out, and it's a strange thing to say, but I began in medical school, so I'll sort of say the beginning of my medical career predates the CT scan, and let alone molecular targeted therapies, PET scans, MRIs, et cetera. Much of that was sort of science fiction at the time. The idea that you could sequence, 500 genes, and you'd be irritated because it takes 2 weeks to do this would have been thoroughly beyond comprehension. So as I, teach every resident, I say, or fellow, everything I tell you is wrong. It's just up to you to prove it. And, so I think that that's where things will be. And, progress in any area ultimately lifts every other area.
Great point. Thanks, Marty. Efrat?
So I get the hardest job to come up with something after everyone really said everything that we're all hopeful for. But to me, this type of event is the start of people really paying attention to aging and cancer. I've been in this area for over a decade, and finally I see something moving. I see scientists interested in this. I see collaborations with clinicians. I see clinical trials that are being supported by our National Cancer Institute. I see patients understanding how important this is, advocacy groups thinking about this, pharmaceutical companies thinking about this. So I am really hopeful that this event basically sets the stage for seeing a lot of progress and development in this area.
Thanks, Efrat. So I'm gonna give a final word. So I'm an immunologist, and so the thing that I am most hopeful for in the cancer and aging space is that many of the chronic illnesses that we experience as we age happen because the immune system either isn't functioning as well as it used to, or it's functioning in ways that aren't productive. It's creating an inflammatory environment that makes our tissues function less well. And this influences, well beyond cancer. I mean, it's heart disease, it's dementia, all of these things are related to dysfunction of the immune system. So my hope in this space is that we'll be able to determine molecularly why the immune system starts to function in ways that aren't productive, so that we can devise ways to reverse that dysfunction and raise the level of productive immunity so that it can influence anything we do, from immuno-oncology interventions to vaccination to all kinds of other applications as we age. So that's the space that I am most interested in this whole area. And I'm very hopeful that in the next few years, we'll make some headway and can bring it to patients' bedsides and benefit them. With that, I just want to thank everyone again for joining us this evening. I want to thank our awesome panelists. These folks have been just fantastic. And I want to thank our exhibitors for participating and sponsoring this event. This is the last Together Facing event for this academic season. We'll start up again in the fall. And so we wish all of you out there and your families safe and happy summer. Go out and do something fun after being cooped up, for 2 years because of the pandemic. So good night and take care, everybody.